Thank you. Can I welcome members, invited guests and public, both here and those watching on the webcast, to today's meeting of the Health Committee. Our main topic of discussion is social prescribing in London. We encourage anyone taking part in the discussions on social media to use the hashtag #AssemblyHealth. First, we have a few short items of formal business to go through. Are there any apologies for absence?
We've received no apologies for absence. We've received no apologies for absence. No apologies.
Thank you. Can I ask members to note the list of officers set out in item number 2 of the agenda, and ask if members have any other interest to declare? No. Okay, thank you. Can we note the minutes of the meeting of the 11th of October 2018? Noted. Can we note the outstanding actions from previous meetings?
Yes.
Okay. This brings us today to the main item on social prescribing in London. I invite all the guests, and I can ask you to do your own introductions for the committee. So if I start with you, Dr. Zoe Williams.
Yep, hi, I'm Zoe Williams. I'm a GP, working not far from here at all. And then I have various other roles as well. So I work with Public Health England and the Royal College of GPs as a clinical champion for physical activity and lifestyle. I work with Southwark CCG around lifestyle medicine and social prescribing, and I also do some media medicine.
Good. Thank you.
Hello everyone, my name is Jennifer Neff. I'm from Elemental Software. I'm a former
service at the Bromley-by-Bow Centre. I also do some link working delivery where we cover 6 GP practices in the Mile End and Bow area.
I'm Mohan. I'm a GP in Merton. I've been a GP for 10 years. I'm also the clinical lead for social prescribing for Merton and Wandsworth.
My name is Vicky, Hobart. I'm Head of Health here at the GLA since February 2018. I've been leading on finalising the health inequality strategy.
My name is Sue Hogarth. I'm Assistant Director Public Health, Camden and Islington. And my role in social prescribing is that I've now worked in 4 boroughs around and doing work around social prescribing, and I also sit on the London Social Prescribing Network.
Thank you.
Hello, I'm Jill Wiltshire. I work in the health team here at the GLA, and I'm developing the social prescribing vision from the GLA's perspective.
Great, thank you. We probably will direct some questions to specific people, but if you feel that you want to contribute something, then please feel free to do so. But we want to get as many opinions as we can, and we are limited to time. So we need to be out of here by at least 12:30. At least that's one of the rooms booked till, okay? And we have other committee meetings to go to afterwards. So we are defined by those parameters. So I just want to sort of get off with a generic question. What is social prescribing? Maybe I'll start with Vicky, because I think the Mayor has a view on social prescribing. I know there's a draft proposal vision going forward, which is not in the public domain yet, right? What is your vision of social prescribing? And secondly, when do you think we'll have the draft proposal in the public domain?
So the commitment to social prescribing vision and strategy for London was one of the key commitments in the health inequality strategy. And the starting point from that is recognising that health and wellbeing outcomes are determined quite fundamentally by factors often outside of the direct control of clinical or professional health and social care services. So social prescribing as a way of organising referrals, signposting and support into a range of opportunities and assets that are available in communities to support health and wellbeing, particularly with a view to tackling health inequalities. So the social prescribing vision has been developed by an advisory group, and we've got a number of people that have been involved in that work. They have commissioned some specific inputs around priorities in London to develop those schemes. They've done a lot of work around where are different boroughs in London in developing social prescribing, both the NHS and local government, and have been putting that together into a set of kind of priority actions which will form the vision around how can we enable local areas to take forward social prescribing, recognise the importance of it in improving health outcomes that cannot be addressed simply through clinical or health and social care services. in the broadest
When
sense.
will it be published?
So we're hoping for that, is at the final stages of kind of design, so we're hoping to go out for engagement, an engagement process, 3-month engagement process on that draft vision, I think in the next couple of weeks,
Yes.
isn't it? So we're literally at the final
So
kind
we'll
of
get it
design
before
stage.
Christmas,
Definitely.
and then there's 3-month consultation on it.
Yeah.
Thank you.
Seeking very, very broad engagement on that.
Great, thank you. Dan, you are on the sharp end of social prescribing, and what's your perception of social prescribing? And
I think the exciting thing for us about social prescribing is that it brings the clinical world and the community world together. And as Vicky has really sort of highlighted, it allows us, particularly I think in the more deprived communities, to support patients who wouldn't otherwise access services to get the support to access those services through the work of the link worker. And I think it's really important to recognise the actual function of link workers themselves. They are, I think, almost unique. I think with potentially inadvertently or without thinking too much about this, we have created a new profession, which is the social prescribing link worker. It didn't previously exist. We're now busy trying to define that role and create training programs to support people to become social prescribing link workers. But effectively, you have somebody there who forms a bridge between the clinical world and the community, who has tremendous knowledge, in-depth knowledge of what's going on in the community, the services that patients can access, but is also a tremendously skilled professional in terms of how they're working with people in a very, very person-centred manner. And I think actually is probably a unique role now within our communities, and one that I think has tremendous strengths and huge opportunity and potential for how you support people, particularly those who are least likely to move their lives forwards for themselves. And I think that's tremendously exciting. I think the other often unarticulated benefit of social prescribing is its ability to help us to reshape the health system, for the health system to have a far greater acknowledgement of what we're all talking about now, a social model of health. Essentially, we've created a health system that is largely curative in its emphasis, and it helps the health system to move to becoming much more preventative and much more engaged actually with its communities. And I think that is one of the really interesting aspects of social prescribing, and it moves the health system towards a more preventative system, early intervention system, and one that actually can develop far greater connections with the other organisations within our communities that are supporting health and well-being.
Dr. Williams, how can the NHS show the benefits of social prescribing, and maybe people start thinking that this is a fake medicine alternative to medicine rather than it's not really true medicine? And what's the view on the Royal College of GPs on this?
I think as a GP, I would say I did a full day of general practice yesterday, and probably as many as 50% of the patients that I saw, their medical, whether it was physical or psychological illness, was rooted in the social problems that they had, whether it was isolation, financial problems, homelessness. And as a doctor, with all the many years of training that I have and a 10-minute consultation, I am not equipped to help that person reshape their life. I'm only equipped to give them drugs so that we reduce the risk of them having a cardiac event or call an ambulance or whatever actions I can take. And I feel it's quite frustrating because we're not treating the underlying problem with a lot of the work that we do as clinicians. We are just trying to stop the disease escalating or trying to help with some of the symptoms. And I think the support that can be offered by this person that's been described, which I kind of see as a very low level social worker, because so many of my patients would benefit from a caseworker or a social worker, but we just don't have access to that. It's not available. But actually what they need is just somebody to help negotiate the very, I know that my patients have access to over 500 different services or charities in our community within Southwark, but I can't keep tabs on what they all are. and in that 10-minute consultation I'm not able to help connect that person with all that support that's out there for them. And I think as a GP working within the NHS, I think that this would be a real help for me as a GP, as well as, you know, an incredible help for the patients.
Thank you. I mean, as a doctor, you said we're only there to prescribe drugs, right? I would say that in the words of Michael Barrett, the most powerful drug in the world is a doctor-patient relationship.
Absolutely. And I think that, for example, yesterday I often prescribe physical activity. That's something that I'm very passionate about. And I recognise that me giving physical activity advice to my patient who I have a relationship with is probably more powerful than possibly somebody who is a social prescriber. But actually, I have 10 minutes, and I'm not sure how long you would normally have with a patient, but
Up to an hour.
up to an hour.
Thank you. And Dr. Sekeram, you're a CCG lead on social prescribing, and so tell me what innovative ways are there in which social prescribing is being now taken on by CCGs, by the NHS?
So I'm clinical lead for social prescribing in Merton. So we started off with a model in 2 practices, and then we rolled it out now to 13 practices covering Merton. Merton's got a deprived part, which is the East Merton, and an affluent area, which is the West. And so we've got coverage of all of the deprived area and also a bit of part of the affluent area. So I think there's a vision now that actually if we can show the benefits both in the practice, both to the patient and also effect on secondary care, that actually this will really help sort of patient care and also all of us as well. So I'd also echo that actually as a GP, when we see patients who are not able to help, it's really frustrating. And actually now you're able to refer to a link worker who can actually deal with them and actually signpost them all, introduce them to someone actually embedded in primary care and not outside the practice. Once they leave the practice, it's quite hard to get them back in.
So the Merton CCG has appointed some link workers?
So the model in Merton, we have commissioned the voluntary sector, so MVSC, who are an umbrella organisation looking at all the voluntary sectors, and they employ the link workers who work in the practices.
So, but who's funding them?
So Merton CCG have given them some funding.
Okay.
The local authority last year in the pilot phase also added some funding towards that as well. And this year the local authority is giving some money towards the evaluation of it.
So there's 13 practices that are involved?
Yeah.
And the link workers are funded by the CCG?
It's funded by the CCG, who then pay the voluntary sector,
yes.
MBSC, to then we commission it to
You commission it from them?
Yeah.
And how many link workers do you need for those 13 practices?
So at the moment we've got 3 full-time equivalents. And they works out 1 link worker working 1 day in each practice.
Okay. And what sort of patient population is this with 13 practices? What sort of patient numbers are there?
So we're looking at 80,000 in the east, and in the west we've got 40, so about 120.
The 120,000 patients, there's 13 practices,
Yeah.
and three full-time link workers. Great, thank you. I'm going to leave it as there'll be some things we'll pick up as the morning goes along, and as we get triggers going off in our brains. But I can ask my colleague Umesh to pick up number 2.
Thanks, Chair. Good morning, Bennett. My questions are to the external guests, and it's 2 sets of questions, and I'm conscious of the time as well, so if you can be brief in your answer. So firstly, really, is getting the message itself. Social prescribing is still a relatively unknown concept. So how do you convince Londoners, how do you go about convincing people that social prescribing actually works, and it's not something up there? If we can start off with you, Dr. Zoe Williams, and then we can just go around.
I think we often assume that patients, given the option of a drug to treat their diabetes or something that they might be able to go away and do themselves and make changes in their lives, I think we often assume that they'll choose the easy option, which is the prescription, but actually in practice, I would argue that that's not true. And I think you're right, I understand what you're saying. Social prescribing as a term for many years has meant so many different things, and we are now kind of defining it a bit more with this model of having a link worker. I think if you put it into the person's into context for that particular person and give them the option that this would be the social prescribing option versus the medical option, I think the majority of people would choose the social prescribing option.
So yeah, every social prescribing programme is different, and a lot of programmes don't even call it social prescribing. In the north of England there's a housing association and they call it the WellBeing Passport for their tenants. So it's about understanding the communities that you're in and understanding the challenges that they face and what works well in your communities, and then building on that and making it accessible. It's really just about connecting people into programmes and services and initiatives and things in their own community. And it's really just good community development. It's been around for years and years and years, and now it's called social prescribing. It could be called something different in years' time. It mightn't even have a name. It might be so well embedded into what we do that it becomes everyday practice and it doesn't even be called social prescribing. But the name of it does, people do say they either love it or hate the name of it, but what we have found is it's just make it whatever it is that's important for your community and
make it relevant.
Yeah, make it relevant and make it something that people understand.
I think the term social prescribing probably
give it your work, so, but if you could just tell us more about Hamlet's experience.
I think the term social prescribing probably originated really to try to mimic. I mean, it was really about getting a term that was understandable by the clinical world actually originally. So of course, clinicians prescribe. So therefore, it became an alternative prescription, and there were things around for probably the last 20 years, ideas around sort of exercise on prescription and gardening on prescription. So I think that's how the term originated probably. But as you've just said, many GPs and nurses or healthcare assistants on the point of suggesting to the patient that they might refer. It's not, I'm going to socially prescribe you. We've got this wonderful person called Najnin, who works in the next building over the other side of the park, and she could probably see you and help you to support you with some of the issues you've just mentioned to me. So I suspect that many clinicians don't actually use the term when they're talking to their patients. And so I think that's probably interesting. I think when we talk about who we are selling social prescribing to, as it were, so absolutely the public, and I guess the public's understanding of the services, as you say, in many senses this is a sort of harking back to good old-fashioned community development, and of course we all know that in our communities in the past we probably had many more people who've carried out these functions. You can think of the role of priests and corner store owners and publicans in pubs, so all sort of carried out some of these functions, if you like. But I think we need to distinguish who we're trying to talk to. I think one of the critical audiences, quite frankly, is the clinical audience. And we need to have clinicians understand social prescribing, and we need to be able to explain it well to them and the benefits to them. And I think eventually we need to incorporate, at the moment social prescribing is not part of the medical curriculum, so when people train to be doctors and nurses, social prescribing doesn't exist on the curriculum at the moment. And I think that's one of the critical things that we need to do, is we need to get social prescribing taught in medical schools so that it's seen as a legitimate part of the role of clinicians to refer people to non-clinical services, just as it might be to refer them to specialists in hospitals or to prescribe them medication. So I think that's part of selling social prescribing, is getting social prescribing into the medical curriculum in our medical schools.
Anything to add to that, Najnin?
So I do some link working capacity. I also like deliver in the community, and I think we don't usually use the word social prescribing as to our patients, but I think they are we don't give patients enough credit in the sense that they really do want to have that ability to self-care and prevent their issues, and so as long as you can communicate that it's practical and you're just trying to help them and trying to identify their concerns and basically be person-centred, that's all the convincing that they really need, to be honest. That's my opinion.
Yeah, I just want to share in Merton, it's glittering, social prescribing. We've got some great momentum going on, and it started 2 years ago when people asked, do you want social prescribing in your practice? No one put their hand up. We started it, and we've realised that actually it does work. And some of the results we showed, it takes off pressure from primary care. GPs don't want to be seeing social issues because they can't deal with it. They can't deal with it in 10 minutes, and therefore, if you've got someone, if those social problems aren't dealt with, they then manifest as physical symptoms, and then they find themselves in the general practice, in the surgery, and we then have 10 minutes, and we then start medicalising them. If we can then offer them a link worker and say, look, this person can really help, that's shifted a lot of my workload away from me, and I don't see a lot of patients.
Can I just come in on the moment? 15 years ago, we used to have citizens advice bureaus. These were people who were embedded in practices, whom I could refer patients who had housing problems, who had problems with their benefits. Now, increasingly, most of my time is taken up for universal credit appeals, right? Okay, and the impact this is having. Do you think, how is your work different from the citizen advice bureaus, people who were embedded in practices 15 years ago, right? And are things like universal credit, appeal cases, the sort of things you take on, Najnin?
So I think the main difference or the asset of social prescribing is that we are very person-centred, and actually we allow the person to identify their concerns. And sometimes, quite often, yes, GPs do pick up on issues, and actually once they come to see a link worker, you then get to see the real case of there's actually a bundle of issues. So I think that's the main difference. And sorry, remind me of the second part of your question.
Well, I was thinking about universal credit. So maybe I should ask you, Doctor. When I see a patient now, right, who is alteration to their bathrooms, right, alteration to their walking sticks, right, when I see patients who have been refused benefits, right, or have a problem with the housing department, they're not really, they weren't on my medical curriculum. But these people need help, right? Do you see social prescribing as part of addressing those problems?
It's a perfect case, and we know our patients. I've been in Merton for 10 years, and I know which ones have medical problems, which ones have the social problems. Before, I've been saying, look, here's a fly, go down to AGK and they'll sort you out, or CAB, Citizens Advice Bureau. Now I can actually get hold of these patients and actually refer them to the person who can then have a look at the benefits, have a look at how they're feeling themselves, have a look at whatever communities. We've managed to find jobs for these link work, for patients who I've, in the pack I've given you. There's a picture of a patient who was treated for depression. We were giving medical certificates, we were giving antidepressants, we referred him to a social prescriber who managed to get him a job as a chef in a local community centre. I don't see him anymore. In fact, I saw him yesterday in another cafe giving me my lunch, and I've tweeted it and Instagrammed it and all the rest of it. But so the bottom line is we don't see these patients if they're properly treated. You need to match the right need and give the right demand. If you start medicalising them, they keep coming back, and then that puts pressure. We can take that 20% off primary care. And these are complex patients. These aren't coughs and colds. These are ones who've had real deep-seated issues. You know, whether this happened 15 years ago, I'm afraid I wasn't a GP 15 years ago. If this happened 15 years ago, then yes, you know, it works now, and we're getting momentum. So, you know, keep going for it.
Just one thing to say. So it still exists, having welfare advice embedded in GP practices. There are many, many practices in Tower Hamlets and Hackney and other boroughs that will have a Citizens Advice Bureau or another welfare advisor doing maybe a half-day session. We need to incorporate that within the model of social prescribing. Our statistics suggest that in terms of the 6 GP practices that we serve, about 25% of referrals coming via social prescribing are for welfare, housing and debt issues. But the other 75% aren't. So they're for other issues. The critical thing is getting them to the link worker who can assess the range of issues. If they only go and see a Citizens Advice Bureau worker in the GP practice, the only thing that Citizens Advice Bureau worker is going to talk to them about is welfare advice, and will completely miss all the other potential issues that exist in that patient's life. They won't have the professional background to understand what those other issues might be. It's very important that the first step is the holistic assessment of all the potential issues that the patient might have, and then secondarily to that, referral on to a wide range of services that can include Citizens Advice Bureau, potentially based in the same GP practice. But first they need the holistic assessment.
Yeah. Sorry, are you finished? Sekeram.
Yeah, finished?
Yeah.
With,
yes, so if I can come to you then, it's all good.
To come back to your point about
this is still the issue of convincing Londoners that social prescribing works.
Yeah, so the 2 issues around convincing GPs that it's a good idea and also convincing residents. So really to mirror what other people have said, but I've spent some time going to talk to GPs about a new scheme that's coming in that will cover the whole borough rather than a little pilot, for example. And it takes no selling really for GPs. You only have to stand up in front of them and say, have you seen anybody that's clearly got loneliness issues, problems with debt, problems with their job? In the last week or so, can you think of anyone? Everybody nods their heads and say, well, what if we put social prescribing in across the borough that could help your patients deal with some of those issues that you don't have time to deal with? So I think something that we need to be careful of is social prescribing can also be the victim of its success. Once it becomes well known within a geographical area, actually then the referrals start. It does take time for everyone to know about it, but once everyone knows about it, GPs begin to realise how beneficial it is for their patients, and the referrals start to roll in, and then you need to make sure that you look after your social prescribers well enough so that they don't actually get swamped. So quite often, once you do a good bit of marketing, the opposite problem, that you've actually got too many patients that come through the system. And really, in terms of the sell to Londoners, to pick up on Dan's point, I've been in discussions where people have spent quite a long time talking about should we call it social prescribing. I personally don't care what it's called, because actually when a GP is in their surgery, they tell us that, as Dan said, go and see my colleague Wilma or my colleague Dan or anyone else, that they can help you with these issues. So GPs don't need to say social prescribing, because that doesn't mean much to your man and woman on the street, but to say some...
Off-putting, in fact.
It could be, but actually in reality they don't say that. They say, go and see my colleague Wilma, who can help you with the things that I can't. And it's as simple as that, really. So a sell isn't hard, because GPs know that they see issues that they can't deal with.
So, okay, just moving on very briefly to the next section subsection of my section, in terms of looking beyond the GP model, and we touched upon this already. So what are your experiences of self-referral and also the link worker model? I mean, you talked about the link workers, Dr. Sekeram. If I can just ask you for your own personal experiences, maybe start off with you again, Dr. Williams.
So I'll share with you an example that came about from a conference many of us were at recently, and this was me chatting to a practice manager of a practice up in the northeast, and she said that social prescribing came about in their practice because her reception staff knew these patients very, very well, and her reception staff were automatically starting to pick up cases where the patient didn't need to see the GP, they needed some support, and just automatically started doing it. So for example, there'd be a patient there, well, this patient was here yesterday and last week, and they keep coming back. So the reception said, ask them what is going on, and actually I can help you with that. Did you know that this is available? And another patient who was bringing in and bringing gifts for the GP, and thought, well, that's a bit unusual, what's going on there? So I explored that, and actually the patient was just desperate, lonely, just wanted some social interaction. So again, was able to link that person. So this practice manager observed that actually my reception staff are helping these people with these issues that the GPs are not, and that's how it developed in her. So that's kind of, I guess, an example, if that answers your question.
So we're working with over 20 social prescribing projects across the UK, and what we're finding is that social prescribing is for everyone, but not everyone needs a link worker, and that's where self-refer is playing an important part. And what we're finding is if we're making the services available to people, they have a number of choices. They can browse and see what's available in their local community. They can refer themselves directly to the programmes and services and the providers. But if they feel at any point that they would like to connect with a link worker, they can do that as well, because we know that the link worker is so important for so many people. We're also finding that the model is extending out beyond GPs now, and we even have community paramedics that are playing a role in social prescribing. There was a woman in the northwest area, and she phoned the 999 80 times in 1 month. And what happened was the community paramedics were able to speak with her and then make referrals to the social, some clubs and a luncheon club. So she was thinking that she was having a heart attack. It was diet-related issues. So she was prescribed to that. And now they booked her in 4 appointments with a GP. They're guaranteed appointments for her every month so that she can, if she needs that interaction, she can have it. So we've got paramedics, we've got pulmonary care, secondary care, all making referrals into social prescribing. Now you've got community pharmacists. It's really broadened out beyond the clinical model, and housing associations are playing a massive role as well in that. So it's changing all the time, but it's great.
I think that eventually social prescribing has grown up as a sort of clinical pathway from clinicians to link workers. I think as it develops, we will, as you say, we will have people employed by a whole variety of organisations who could potentially fulfil this link worker type function. It's not hard to imagine housing workers, but children's centre workers, school parent liaison officers, all being trained up to have this the skill of at least the initial one-to-one kind of assessment chat with somebody, and then potentially everybody could be hooked into the same system of what these services are that are available in this community, the 100 or 120 organisations or whatever that are available here. And there's absolutely no reason why those lists of services available couldn't be connected, and you could get those frontline staff to be, including the social prescribing link workers, to be sharing that information and creating a consistent approach within a given locality. And I think that's one progression of social prescribing. I think the other progression is this idea of self-referral, which is essentially that people will be able to seek out that support themselves rather than necessarily first going to see a doctor or a nurse to get access to the link worker. And we know that in our case, for example, people who have had positive experiences in our social prescribing scheme then recommend seeing the link worker to their friends, family and neighbours. If they meet people who've got similar issues to themselves, they say, well, go down and see the people at the social prescribing scheme, or whatever they call it. So self-referral then starts to take off across a locality, because people start to know, it starts to become more known on a local basis. And of course, that again reduces demand on general practice, because people aren't seeing the doctor first in order to see the link worker. They're seeing the link worker directly themselves.
Yes, so our scheme had recently started self-referrals about a year ago, and it was like a very slow start, but actually in the last 3 or 4 months we're starting to see an increase in self-referrals, and they're all appropriate referrals, and sometimes they call in times of crises, so you know they're at risk of being homeless and things like that. And I think it's really important that, you know, we're expecting them just to see a GP first and then get referred to our service. We're actually giving them a chance to actually self-refer themselves to capture a wider net of people, or the vulnerable groups that you might not capture, so migrants, people that are homeless or at risk of being homeless, those groups.
I think there's different levels. I think you got at the top of the level, you've got the intense link worker where a GP endorses their service, and we had the patient who came earlier, and I asked her, I said, what would have got you in if you didn't see a GP? And she probably wouldn't have got in contact with the social prescriber. So I think the GP actually endorses it. I think you need to see this prescriber, they'll really help you, and they can do X, Y and Z. It's firstly, and I think certainly these vulnerable patients who know their GP for many years are more likely to sort of take that on board. My slight concern with going self-referrals is whether the demand, you might then get a kind of onslaught of patients coming in. In my practice, we've got a waiting list of almost 2 months, and my prescriber said, look, no more. So I've had to, he's waved the white flag. So that'd be one thing. But if there's another model where, you know, self-referrals can be done online, and I know Jennifer's looking at sort of some work in that area where patients can actually have a look and see what services and maybe follow a pathway, that might be a good way of doing it.
One thing that I was surprised about in a recent evaluation that we did in Tower Hamlets was within an 8-month period, 11% of our referrals were self-referrals, and this was with hardly any marketing. I think there was a poster and some leaflets in the practices, and yet there were still 11% of the referrals that came through were self-referral. And I think, coming back to what Dan mentioned around people talking to their friends and family once they'd had a positive experience. So from very little marketing around this scheme, we saw, you know, a good couple of hundred people accessing their social prescriber. So I think it's still early days in some places with social prescribing, but as it becomes better well known in localities, I think social self-referrals will take off even more, as Najnin demonstrated.
You did something in Tower Hamlets?
Yes.
What was that?
So this was a social prescribing scheme that went across the whole borough in Tower Hamlets. So the Bromley-by-Bow Centre is in
So you worked with local?
Yes, so it included the data from the Bromley-by-Bow Centre.
Can I just come in there? In Tower Hamlets, all of these extra activities are free if you're prescribed. Is that right?
So not necessarily. So what a social prescriber will do is once they've identified the needs of that person, they will, I'm talking of Najnin slightly, will offer a range of appropriate support that is out there for that person. Some of those things might be free. There might also be some services and support that's got a charge to it, but actually a social prescriber will work with their client to find the most appropriate thing to support their need, really. So it could be anything really that's in the community and voluntary sector or provided by the council or the NHS. So it really is about matching the need to what support is out there, and then the social prescriber talks through, well, if there's a charge for a service, would you rather do something that's free? So it's a conversation about what's appropriate for that person.
Yeah, I'm just mindful of the fact there's many boroughs with very little that is free for GPs or people to send.
There's a surprising amount. I mean, some boroughs are more fortunate than others in terms of their community and voluntary sector, but I think in the Tower Hamlets evaluation, I think there was very few things that were that there was a charge for. Residents were prescribed to, I think, 280 organisations for 333 activities. So that was just in 1 8-month period, and I think very few things that there was a charge for.
That's exceptionally good there.
Yeah.
Okay, thank you.
Yeah, okay, thank you. Jo.
Yeah, some of my questions have been answered. It was about the role of GPs, and I think we've sort of looked at that a little bit. But how many, do we have any idea about how many GPs across the city are actually using social prescribing or have it embedded into their practice? Do we have any idea of that yet?
It's probably, how many GP practices are linked to a social prescribing scheme? I'm not sure what the figures.
We don't have those exact figures, I'm afraid. And we know that there's services across about 25 of the London boroughs, but some of those are embedded within GP services, but some of those are services run by charities. The national NHS social prescribing team are doing quite a lot of mapping at the moment about what is happening across the country, and our colleagues at Healthy London Partnership are doing some mapping around London in particular, and sort of trying to drill down those figures. But we don't have the exact figures of the number of GP practices.
I think it's fair to say that there are some boroughs that have whole borough schemes, Waltham Forest, Tower Hamlets, Hackney, and maybe some others that I'm not aware of, but some boroughs have partial coverage, like Merton. You cover what percentage of your practices?
13 out of 23.
13 out of 23, and there will be other boroughs with no social prescribing at all, and some with smaller schemes. I think Newham has a small scheme, for example, that covers, I can't remember exactly how many, but a small proportion of the GP practices in Newham, for example. So there's quite a lot of variation at the moment in terms of coverage.
And I would say some schemes who are doing something but branding it as social prescribing
may not fit our definition of it.
But I'm not going to name.
So can I ask the two doctors we have here, are there any particular skills that GPs need to be able to use this model effectively? And I suppose as a GP, what do you need to make it effective from you? How, I presume because you're busy, it needs to be quite a simple model that you have.
I think you just need to listen. I think as a GP, you know your patients, what is their concerns, what's their root cause, and I think if you can identify what it is, and before you can then offer that support to the patient. That's all you need. And I think once you've got a few cases, in Merton, I mentioned two years ago, no one was really interested in this. Now I'm getting GPs knocking on my door saying, when are we getting it? And I'm saying, I haven't got the money, it's not me, the CCG. So I think once you can see the cases and show what happens and pictures and videos, HLP kindly did a video for us, which was really powerful. So I think it's just listening to what the need is and actually matching it. Before, if you can't, as GPs, if you don't know what service or how you can help the patient, you just ignore it, you just go around the issue because you've got no way of helping it, so it's frustrating.
Yeah. So I think GPs have the skill that they need to utilise this. I think they just need to have the faith in the system and the faith in the link worker as well, just to know that their patient will benefit and won't be harmed. And I think that will come when that patient comes back or doesn't come back, which is often the case. I think we our confidence in any service that we refer to goes up if our patient comes back and tells us that they had a good experience and that they were treated nicely. And I think sometimes things like Citizens Advice Bureau or housing, or when they go, often they come back and they feel that the way they were treated actually, you know, put them off and they were intimidated. So I think GPs have the skill and will feel confident in using it once a few patients come back round to them and tell them they've had a positive experience.
Good. And Dan, you were telling me a little earlier that when you first set up this, you had a multitude of different forms that GPs had to fill out if they wanted particular services for their patients. So as far as you're concerned, what model is needed to make it effective?
So hilariously at Bromley-by-Bow, we deliver, I mean, we're a very large third sector organisation. We deliver something like 40 different services. So our poor GPs at one point must have had 20 or 30 referral forms, some of which were 4 pages long. Of course, at that point, any referring party just simply stops referring altogether. It's all far too complicated and confusing, and they're never quite sure if some of those projects may have come to an end or whatever. So we subsumed all of those forms. The remit really was, could we create a form that was simple enough to be completed in less than a minute? Could we embed it on the computers within the consulting rooms in the general practice? Would it draw down the data about the patient onto the form without GPs having to laboriously type people's names and addresses and dates of birth and so on? And that's what we did. We then spent a lot of time doing presentations in the practice. So myself and the then link worker did lots of presentations to the staff within the GP practice, and then when we rolled it out to the neighbouring 5 GP practices, again we went into those practices and did lots and lots of presentations. It was critically important that the referrers personally had met the link worker and that they knew who they were and they had a degree of confidence in this person, that they were going to get a friendly reception, that their patients were going to get friendly reception from that person. We also did quite a lot of work describing what the sorts of services were. It became apparent that it was very important for the clinicians to understand, well, what happens when somebody sees the link worker, and what happens if they go on to see a welfare benefits advisor or the employment team or the time bank or the gardening group or whatever, because as the clinicians told us, they need to have a picture in their own mind's eye of what that journey is likely to be like for the patient, so that they can then conjure up in the patient's mind's eye what that journey will be for them as well. Because essentially there's a whole process of creating trust and belief in what's about to happen with the patient. And the clinicians were very keen to hear, actually, we got some of our own practitioners in, like our welfare advisors, our employment advisors and so on, to also talk to the clinicians about what their service was, so that the clinicians could understand what's that journey likely to be like for my patient.
Can I come to Jennifer? And I want to ask you, because my next question to all of you really is, how do you judge it's been effective? But looking at your website, which is what I'm doing on here, it seems that if you self-refer and download your app, you can then track. So if you're given exercise, you can track a bit like a Fitbit or something. But it looks like it goes to all the stakeholders that's referred you as well. Yeah. And do you want to just explain a little bit about that? And then I'll ask doctors whether that's something that you need or would be useful.
I think it kind of carries on from your previous question about what do clinicians need. So technology it can be a barrier or it can be an enabler in this. And when we spoke to GPs, they told us, I'm not going to log out of my clinical system and log into your platform. I need that seamless connection. So we spent a lot of time making that happen. So you've got people using different systems all over the UK. You've got all the different clinical systems providers. And what we've done is made it really, really easy for them to make that referral from EMIS or whatever straight into Elemental. And that form, we've actually timed it at 45 seconds. So we've got it right down. And that it generates that referral form, and then you can send it to a link worker that's close to where that person lives. And you can also state the reason for the referral. So what we're finding that most of the referrals at the moment are being made for debt advice, social isolation and physical inactivity. So then you've got a picture about what the referral is for. The link worker is able to access the referral form within the platform, and then they're able to carry out that assessment, carry out that baseline analysis to be able to see what are the things, that the challenges that this person's facing, what's important to this person, what do they like doing, and you can get a real picture about the person. That's then able to be shared out with the different providers. So they might choose that they want to join like a walking club and maybe join the men's shed. Those referrals can be made then through the platform. So it's accessed through a URL and it's accessible by all the different stakeholders. So you start to see, okay, I made the referral, but a lot of the challenges up until now have been, what happened? But the community doesn't always have the time to go back and say, oh, thank you, Dr. So-and-so, we've got your referral here. This person was actually suffering from high anxiety levels. They are now actively engaged in 3 or 4 things in their community. Over 6 months, their anxiety levels have dropped, which means that they can now, and they don't have time to do that, but the digital is actually providing that functionality for them, so that GPs can say, we've been talking to GPs who were making no referrals, and they're now making 50 referrals a month, because it's so simple and so easy, and they've got the full picture of what's happened beyond that point of referral. And that's what they need, is the confidence and to know that it's actually working, that it's happening and it's easy. And then to be able to say, well, what's the impact on the health and social care system, what's the impact on GP appointments and A&E reduction, and all that is available as well.
Okay, so then to my next question, how do you judge whether it's been successful? Is it just by saying, I'm not seeing this patient anymore? Is it?
So I suppose you've got qualitative cases, so you've got patient stories. We've got a great video in Merton that shows how it's really impacted on them, the patient story which came today, so that's the qualitative one. Quantitative, you've got effect on GP practices, so the reduction, again in the pamphlet, the booklet, there's some data there which shows that there was a reduction of 33% of patients who were coming back and seeing their GPs as a result of social prescribing, so that's on primary care. We also looked at secondary care, and there was a reduction in A&E attendances as well, by 50%. We're doing more in-depth sort of work in it this year, along with Tower Hamlets, and seeing the real impact, and early results have been quite promising. So I think they're your 3 measures. And I think also for the patient, for the GP and the clinician, being able to sort of do some questionnaires for the health and well-being of me has really improved as well. I can help these patients I wasn't able to help before. So I think with all those, you can really evidence it in a nice package.
Can I just I was going to come to you anyway, because you said particularly about self-referrals, once they start, it's like a snowball effect, and you've then overloaded the system.
It is. I mean, you do need to embed in a social prescribing scheme support for social prescribers themselves. They're seeing very, very complex cases, not cases that necessarily need social care input, for example, but they're seeing people with all sorts of things going on in their lives, and so you need to make sure that you support social prescribers so that they're not overloaded, but they understand their role in terms of their role is to link people to services, to sources of support, not to case work somebody for a long time. So social prescribers need support themselves to know when their role ends, and they let the other support services then go on and support residents. So we do need to make sure that services embed support for social prescribers. But just to come back to the evaluation piece, I think it's really important that we do include a range of information when we evaluate a service. It can be quite reductionist, I think, to just look at A&E attendances and GP appointments, whilst brilliantly it's showing reductions in those. If you've got somebody who's feeling much more resilient as a result of a social prescribing intervention, and they've got a long-term condition that they weren't managing before, they start managing their condition and going to see their GP. So in some cases you might see a rise in people going to see their GP, but that's absolutely appropriate because they are then managing their long-term condition, as opposed to before, when all they could really think about was dealing with their financial situations or their social isolation. And also it does depend on who's funding a social prescribing scheme. So typically if a CCG is funding a social prescribing scheme, they will be looking for reduction in NHS use. Other people might be looking for something different. Looking at the journey that people have made in terms of their health and well-being, so quality of life improvements is really, really key. And one key question for me when talking to residents is always, would you have accessed those other services without your discussion with the social prescriber? And in the patients I've spoken to, they've all said no. So in terms of how effective that link worker is, we're not evaluating necessarily Citizens Advice Bureau or a gardening club down the road, but what we are trying to evaluate is, did that social prescriber intervention mean that people could unlock other things in the community?
And that's, I suppose, my final question this session. We talked about whether GPs need skills. I suppose it's what skills? Is there a training programme out there for social prescribers? Are they all going to be uniform, or are there different skills needed depending on the thing? And I think that's a big issue. And could volunteers be trained to do that sort of work?
I think, as I said earlier, so the social prescribing link worker function is a new profession, essentially, that we've created. It's quite variable at the moment. People are coming into becoming link workers from a whole range of different previous jobs and backgrounds, as it were. And interestingly, to some extent, that variety actually brings strength to the link worker function and people's previous work. We have been commissioned by NHS England to devise the first accredited training programme for social prescribing link workers. We've been working with a couple of partners on that. And so the scheme we will deliver the first pilot actually in the north of England starting in January, so we'll be running the first scheme. It's a level 3 qualification. It's a nationally recognised qualification now. It's awarded by CERTA, which is an awarding body. It's about 20 days in the classroom and about an equivalent number of sort of days of practice as well. So it runs over about 6 months, 1 day a week. Now, interestingly, there are discussions around, is the level too high or too low? Just so you know, level 3 is the equivalent of A-level level. So there are schemes. Chris Drinkwater scheme in Newcastle has particularly taken the view that they want to employ people from the deprived part of Newcastle that they serve. They've got a journey which takes people through being often social prescribed themselves, to then becoming buddies and volunteers, to then a journey into employment as link workers. And they're busy devising a level 1 qualification, which they think will be the starting point for those people in terms of gaining accreditation, which I think is really commendable. And then there's undoubtedly a view probably that when people start to become managers of scheme like Najnin, they may need a higher qualification as well. So I think we will end up with a suite of qualifications. We're also piloting, again with support from NHS England, some non-accredited training programmes here in London. Bromley-by-Bow will be running two-day non-accredited training programmes for skills for link workers, which I think is important. One of the challenges for many schemes is actually releasing their link workers for 20 days, which is a challenge just in terms of their funding and their model and dealing with demand while they release their link workers. The other thing I think that is important probably is to start to create peer networks of link workers so that they can support each other as well, and potentially with some professional input into those peer networks.
That's really helpful. So did you want to say anything?
I was just going to say, I think that sounds brilliant, because 2 points really. I think one of the biggest skills that a link worker can have is a lot of it is about who they are as a person. Somebody who wants to, hopefully the people who want to take on that position are the right type of people, because it does require a really sort of non-judgmental, caring nature. And the other thing, I think this is one of the areas that's lacking at the moment. I know within Southwark we do have some link workers, but I think their training is 1 day, which is just not, and that training is mostly around the various different charities, third sector organisations having 10-minute slots to tell them about what they're doing. So no real training around consultation skills and that type of thing. So I think it needs work.
Do you want to talk about that? Vicky, you want to come in?
Just back to this.
Sorry, just adding to that, also another part of the link working role is just having constant engagement with the voluntary sector, because of the voluntary sector, the nature of it. There's so many projects and services that are short-term funded, and so it's sort of engaging, okay, what's out there to replace that. So you go into these places trying to, info gather, and also try to get people to the appropriate services, and that takes a lot of time as well.
Sorry, Vicky.
Sorry, just to add on to the question about how would we know it's how would the NHS know it's working? So the National Institute of Clinical Excellence has started doing a bit of mapping against all the guidelines it produces. It produces public health guidelines and clinical guidelines, and a number of those guidelines for clinicians would involve, at this stage, refer to X. So there's quite a good understanding of just how wide that volume of pathways is that this could impact on. So across diabetes, mental health, learning disability, musculoskeletal problems, etc. So from an NHS perspective, when you're looking at what difference it makes to outcomes and delivery of some of those pathways of care, there's quite a lot that we could, as the schemes get more sophisticated and better coverage, you can look back to what impact that's had on those pathways. And then the other bit, which you might have a question in a minute on anyway, around local government. So the question where we're looking at health and care systems developing in a more integrated sense, what are the care outcomes that these schemes are also impacting on? So having come from a borough doing a lot around adult social care, a lot of the partnership working, which I assume is part of why you're in that partnership with Merton Council, is around, well, what does this mean for independence, choice, control, maintaining, an active position in the community, etc. And really looking at those health and care outcomes and what that means for kind of the sustainability of local health and care systems. So some quite important questions around sustainability of the care system as well as health and well-being outcomes.
Great, thank you. Andrew.
How do we generate the money for social subscribing? How do we do it? What's the best funding streams? We've heard some examples. And how do we persuade people to part with the cash?
Happy to take that one. I love talking about money. So just to give you an overview of some of the projects that we've been supporting, where they've been getting the money from. So Public Health Agency funded a big project across Northern Ireland for 2 years, and that then they were able to get the results then to be able to go to big lottery, and they got £3 million for a 3 to 5 year project that's covering the whole of Northern Ireland and parts of Scotland to tackle loneliness. The London Civic Challenge here funded a project in Ealing. So that was money that was used to be able to get social prescribing off the ground. It's called Social Prescribing Plus, where the community is actually walking through the area, I think it's Havelock area, and looking at what the assets are and what the great things are, and trying to really galvanise that and make the GP practice be a centre of wellness as well as treatment. Department of Health money, that's been coming through as well, so lots of different projects are funded through that. Housing organisations are paying for a lot of social prescribing projects. They're saying, we'll pay for a pilot for 1 or 2 years, start to show that it works, get the right people around the table, and then approach the CCG. So there's different ways to kind of lever it. You've got public health, you've got secondary care. Mercy Care NHS Foundation Trust have paid for a big social prescribing project up there. And GP federations as well. So it's all about gathering the evidence, unblocking the blockages, getting the right people around the table, showing that it works, and making that information available to commissioners, and really building the case to say, this is working, it's happening here, why would you not fund us?
Yes,
also to say, I think that's where the focus of GLA has been really helpful. So social prescribing being in the health inequalities strategy, and bringing us all together as London people who are involved in social prescribing as a national social prescribing network. We've all done bits and pieces of evaluation, but actually all coming together and sharing some of those things and being able to demonstrate en masse how useful social prescribing is for our residents. I think that's part of the process as well. So the focus of GLA on social prescribing is very welcome, I would say.
I think our long-term goal must surely be that social prescribing is mainstream funded by recurrent funding within clinical funding and also within local authority funding. I think that the social prescribing has benefits to both the clinical world, and we've talked about those, but also to the local authority world as well, and Vicky's mentioned around social care and social services as well. So I think the benefits accrue across both the local authority spending and indeed potentially police and fire and all sorts of others actually, as well as the clinical world. Bringing together commissioning of social prescribing, therefore between the clinical world and the local authority sector is I think critical. I think our goal has to be that social prescribing is not seen as discretionary, but is seen as an integral part of the provision for communities in London, an integral part of the health system, the social care system, the local authority system for London. If we believe, and I think we probably all do around this table, that, as Michael Marmot would tell us, 80% of health outcomes are socio-economically derived and 20% are thanks to the good work of the NHS, then the logic is social prescribing. And it shouldn't be seen as a nice to have, but it's absolutely an integral part of what we're trying to do, all the more so for the more deprived communities. In Tower Hamlets, we have almost a 10-year healthy life expectancy gap, and even worse, a 20-year healthy life expectancy gap and a 10-year life expectancy gap. Michael Marmot would tell us that the only way to close those gaps is to support patients to improve their socio-economic determinants of health, and that is what social prescribing will allow us to do. And that then has benefits, as I say, across the system. We know there's a statistic, isn't there, that 1 in 7 procedures in hospitals shouldn't be happening. So we need to start to examine funding differently.
I understand that, and there's been example we've heard about, but there is ad hoc funding, and as you so rightly said, what we need to do is mainstream this. But whenever you get involved with an argument with the Treasury, and ultimately that's who we're going to be talking to, they need a little more than a few examples of where it worked. They need something a bit more robust than that. Are there any studies? Are there any cost-benefit analyses that can absolutely prove the case? Because when NHS money is so limited, they're not going to throw money away on something that's just hope.
I agree with you, and we were at the King's Fund, some of us were at the King's Fund, and one of the questions on the slider was, where's the money? It was Matt Hancock was standing there, and he didn't have an answer, and it was literally, unfortunately, as much as I love the quality of cases, we used the Wellbeing Star in our study also. The evidence does actually show, and if we can show the evidence in A&E, show the evidence in secondary care, elective admissions, also outpatient appointments, that does show a real cost saving. And I think that would be a cost-benefit ratio in terms of taking to the Treasury or who holds the purse string to say, look, this is where we're saving money here, this needs to go into social prescribing, and better still actually to the voluntary sector.
But also to say, we know that there are some intermediate things that have a huge impact on health and well-being. So we know that dealing with somebody's social isolation won't necessarily save money in 12 months' time in terms of the GP attendances, but we know if we deal with some of those issues, it will save a huge amount of money further down the line. Now, in the evaluations that I've done, I've never costed up the proxy, I've never costed up the intermediate things that social prescribing has dealt with, which could save the system huge amounts of money. So sorting out, getting somebody into work, we know that saves the health and social care system huge amounts of money. It saves much more than a social prescribing scheme would cost.
So it's the kind of activity that maybe a social impact bond could apply to. We could apply a social impact bond. Is that?
Possibly, but
just whether whoever's sponsoring it would want to take that.
It's difficult. Social impact bonds aren't easy.
Yeah,
but there is a scheme.
Possible vehicle, yeah.
But Newcastle actually has done this, so they're 5 years into a social impact bond in Newcastle. And I spoke to the people there fairly recently, and they've got some tremendously positive news coming through. Essentially, I think it was about £1.2 million was the social impact bond that they took on, and then the statutory sector agreed to pay the outputs if they were achieved, and that pays off the bond and then forward funds the programme. And they are now moving into very, very positive territory, and indeed they may soon be in the position to pay off the bond early, which is really encouraging, yeah.
I think we do have enough information, and there are studies that have been done, some academic studies that have been done, but what we haven't done is brought it absolutely all together. But there is a huge amount of information out there about cost savings and about the benefits, definitely.
Ms. Wiltshire, you say?
Yeah, I just wanted to add that the government launched their loneliness strategy and beginning of October, and in that there was a suite of things around social prescribing, including developing connector schemes, CCG-led connector schemes for social prescribing schemes across the whole of England. Now, that didn't have a particular amount of money attached to it, but we are expecting, hopefully within the next couple of weeks, the NHS 10-year forward view to be announced, and we have been hopefully reliably informed that there will be some announcements within there about funding nationally for social prescribing. There is also, my colleagues at Healthy London Partnership are developing a social fund, a London Healthy Social Fund, and social prescribing will be an aspect of that. And obviously in that they're exploring social investment and social impact bonds and other ways of investing in social prescribing.
Ms Islam, you said earlier about the liaising with the voluntary sector, the third sector, in order to ensure the capacity is there for social prescribing. Do you think Tower Hamlets is a particularly well-developed third sector? Other boroughs don't have as well-developed a third sector. What needs to happen in order to prepare that third sector for this rush of prescribing?
Yes, so Tower Hamlets, I would say, is in a very unique position where the third sector is very well developed and very well connected as well. And I think that's just the history of the deprivation of the borough. And I think just having everybody come together, so having engagement with link workers and the voluntary sector, and that's where the social prescribing link workers really do come into effect. So we're linking the clinical to the voluntary sector.
Do any of those third sector organisations say, actually, we can't cope with that?
So at the moment, currently, so sometimes, like, for example, food banks now with the rollout of universal credit, everyone's just being, it's really difficult. Everyone's just going above and beyond at the moment. I think that's just where we are at the moment. But I would, it's in a very fragile position, and we need to think about how the voluntary sector is maintained and is sustainable, because their funding is so short term, and that's something to definitely talk about.
It needs a really sort of joined up approach, doesn't
yes,
it, at
definitely.
a local level? And are there any structures in place currently which GPs and the NHS and the local authorities and community groups, is there any structure there at the moment where they sit? Miss Hobart, sorry.
Is it? So just chip in. So building on our previous, so health and wellbeing boards as the places that lead the health and wellbeing strategy for the place, the health and wellbeing commissioning strategies for the place. In a lot of places have been the forum where the different parties come together. The leadership for social prescribing can come from quite different parts of the system. So in some cases it is very, very GP-led. Other boroughs it's been very social care-led. Public health teams may play a particular role. So what we heard earlier about the schemes evolving in slightly different ways, both to meet the needs of local communities, so they have to fit the needs of communities in terms of the health and wellbeing profile, the funding situation, bearing in mind significant constraints, for example, on local government in terms of its investment in the voluntary sector often. But that would be the strategic forum that I would say in most boroughs would be where that conversation about both the funding, the focus and the delivery, because you're having honest conversations with the voluntary sector there around a range of priorities, and how that would come together. So I'd hope that would be the forum in most boroughs where that would come together.
Yeah, I was just going to say it's a real problem in Merton, actually. We've actually increased the real demand on the voluntary sector, and they're making a lot of noise saying that where's our funding? And we're looking at the valuation upstream, so where is it a GP practice, where it's a social prescriber, but actually downstream where the voluntary sector is actually taking all this on. It's very, very tricky. And we had an engagement event a couple of weeks ago, and it was kind of breaking the ice. We've still got a few more to go, but that's something which I think's slightly been overlooked. But the other thing I'd like to say as well is actually, if we're finding 20% of patients who shouldn't be in the GP practice, and that should be in the voluntary sector, should be elsewhere, then actually that's probably where they should be seen in the first place anyway. So actually it's a social issue, not a medical issue. We're actually putting them in the right place. But how we fund that, I haven't got an answer, but it's, yeah.
One would have to suggest that after a period of time, the statistics coming through social prescribing should be a really strong indicator or informer of commissioning decisions. So if your link workers are saying it's really hard to place patients with mental health issues because there aren't any community mental health projects, or welfare benefits advice is totally overwhelmed, as it probably is all over London actually. And through social prescribing, we're creating more demand, or we're identifying more demand for welfare advice, and yet there's already a queue outside the Citizens Advice Bureau every morning. You know, these should start to become indicators that start to say, actually, this is where commissioning needs to increase supply of services. And I think social prescribing, indeed in Rotherham's case, for example, that's exactly what they've done. They've used social prescribing as a great way of determining what the services are that are needed in Rotherham, for example.
Just to go back to your point about how people come together to talk about social prescribing, there's obviously the health and wellbeing boards, but operationalising social prescribing can be really useful if you've got a steering group that includes all the partners that you've just described. So making sure you've got a rep from the community voluntary sector, having a social prescriber there is absolutely completely important. Having the commissioner there and having the provider there. So actually having everyone around the table as you're developing the service can do an awful lot to create an understanding about what it is and the impacts that it might have on each of the organisations.
Don't all these agencies suffer already from meeting fatigue?
I found it to be really useful in terms of getting social prescribing off the ground. In fact, we couldn't have done it without that steering group. And some of the conversations that Mohan just described, by having the steering group and also some of the engagement that Najnin has described, we went from a situation where there was quite a lot of animosity locally about the social prescribing scheme and the impact on the community and voluntary sector, to a situation where there was a huge amount of understanding, and also the community and voluntary sector organisations told us that actually it was a really good way of generating referrals to their organisation. So social prescribing, so they would get automatic referrals to through a social prescribing, that each organisation wasn't having to pound the pavements to all the GPs. The social prescriber was the person that could raise the awareness of their organisation. So the relationship changed quite a lot. It took about 18 months, but it was very positive by the end.
Some of the most exciting conversations that you see are when those people all come together. There's examples in the Northwest where local authority, CCG and housing are putting all the money into the social prescribing programme. Rotherham, as Dan said, is a great example. In Northern Ireland and Scotland, when the big lottery programme was being funded, the money was following the patient. So they were saying, okay, there's an allocation for the voluntary community and social enterprise sector, so that you now have the capacity to be able to deliver on that. And if there was a recommendation to be made, it would be that the voluntary community and social enterprise sector was recognised and rewarded for their role in social prescribing, and rewarded in a way that the money was there as well when the programme was being commissioned, that they would be getting the money to be able to do that.
Thank you very much for that. Most of my other questions have been answered, to be honest, but there is one that I wouldn't mind throwing out to everybody except Miss Wiltshire and Miss Hobart. That is there anything more that the Mayor could be doing in order to convince... Well, we'll come on to you next, don't we? Is there anything more that the Mayor could be doing with his convening power to be able to advance social prescribing?
I think for me, one of the interesting things, because up until now, the majority of funding and commissioning of social prescribing has been from the clinical world, logically. I think the idea of co-commissioning, so encouraging the 33 London boroughs to co-commission social prescribing in tandem with their CCGs or GP care groups or whatever they are, bringing these two together, I think would be very, very interesting, and helping to support that to happen, creating a model of co-commissioning, I think would be something that the Mayor and the GLA could really strongly support. Would be one of the suggestions that I would make.
Anything else? Yeah. Yes. Oh, Ms. Hogarth and then
Susan will pick this up.
20 minutes.
No, but Susan will pick this question up anyway.
This
was her question.
Don't worry, it doesn't matter. I'm fascinated by the answers anyway.
Oh, okay. Do you want to...
No, do you want to finish that?
Ms. Neff first, and then... Sorry.
Looking at maybe, and this would be difficult to do, but a number of boroughs, and really focusing the attention on, I'm not sure, like a specific area, and making this like some kind of super duper social prescribing area where everything is just, you know, working so well. You've got all the right stakeholders, all the different systems are speaking to each other, people are being supported and the outcomes are being reported and almost using that as a kind of a really good practice focus to be able to say, because it's going to be hard. I suppose everyone's at different stages with social prescribing, and it's recognising that, you know, there's different levels and different stages and different resources available to people, but almost like looking at 2 different stages within social prescribing and saying, look, there's a fantastic model here on our doorstep that we can use as some kind of example to everyone. So really focusing on that would be great.
Ms. Hogarth.
I think raising the profile has been particularly helpful through the inequality strategy. I think bringing everyone together across London has been really, really useful in terms of us learning from each other, and also persuading perhaps boroughs who aren't doing it to also do social prescribing. Your comment about talking to the Treasury, him talking to the Treasury would be brilliant about lobbying on behalf of social prescribing. I do worry about social prescribing not being business as usual, and so kind of the short-term piloting of social prescribing and the increasing need to evaluate every single tiny bit of social prescribing when I feel that we've got enough information to say that it does work.
Yeah, that's that you never go to the Treasury unprepared. You've got to make sure you're right. Yeah. Actually, what I'll now do is I can hand over to Susan, if that's all right, because they merge into one.
Do indeed, thank you. I am impressed by what I've heard, because I've heard very little about this from where I live. Now, my questions are, does the vision do well, and what does it not do so well? Can I confirm, have you all seen the vision? Have any of you seen the vision?
Yes. I've seen it earlier, yeah, not for a while, but yeah.
You have? Only none of us Assembly members haven't, so which hasn't helped, but never mind. So those of you that have seen this vision, what do you think it does well?
It definitely puts the voluntary community and social enterprise front and forward. It's so important. It also focuses on the workforce side of things, so link workers, and it really, you know, until now sometimes it's been a little bit fluffy around signposting versus. And it really says that link workers are key to social prescribing because of all the reasons that you've heard here today. It's put digital out there as well into the forefront as being an enabler, and it's also put social welfare legal advice very much out there too, to say that, you know, social prescribing programs need to be able to cater to the social welfare legal advice that's required, because people aren't going to go on and join Parkrun if they're trying to work out how they're going to pay their rent. So it's really focused on key areas like that, from what I can see.
Okay, anything different?
Yeah, I mean, it was great. There's 2 bits I'd probably add is support for social prescribers. So they come into contact with some real, you know, vulnerable adults and angry patients as well.
Yes.
You know, really, and we've had a few issues in terms of some of the social prescribers being really upset by some of the stuff they're seeing, and actually support for them. And I think maybe something around that would be really useful. I think also maybe the voluntary sector as well, maybe a guide for them in terms of what can support them, how they can support themselves, and, you know, maybe how they can evaluate themselves. That might also add to the strategy and the vision.
Okay, so
a few things. I thought the way it describes this person-centred approach about social prescribing in terms of its dealing with what matters to that individual rather than what matters to the system, I think is really important. So person-centredness, but also I thought it was really helpful how it picks out every player in the system around a resident. So why social prescribing is one of the titles for one of the sections, and it talks about the individual, the health service, social care, community and voluntary sector. So I think it quite well paints a picture of the system that we all need to wrap around a resident to support them. So I think it's a really good vision. I think there's still time to tweak it with the engagement process. So we've already worked out something that's perhaps missing, but there's time to put that in. So I think it's a really good solid start and paints a picture of what social prescribing should be.
okay, and what does it not do so well? Any takers on what it doesn't do so well?
I guess just highlighting the role of link workers, and just it's, you know, we need that support, because I can imagine like it will go at capacity, and we just need some supervision as well. So like you said, we do have really complex cases. Last week I had back-to-back abuse, suicidal ideation, bereavements, and when you're dealing with those sort of things, just as a human being, you have
Yes.
to process that. You could argue that we need social prescribing, you know, but it's just protecting the workforce, because currently, you know, the link workers are going above and beyond just to make sure that they're connected to the right services. We need to be very careful that we don't lose the existing workforce that we have and protect them.
Okay, and of course if it becomes successful, you'll be, you know, required even more. I'm sure colleagues have taken note of that. So if I ask,
Can
really...
I also add, sorry,
yes,
ethnic groups as well. Explain to patients who speak English is great, but speaking those who don't have English as their first language, who probably are more vulnerable and are more found in deprived areas, trying to explain the concept when we don't speak their like can be quite tricky. So I don't know, some kind of awareness can be done in that respect would be quite useful.
I think it's quite helpful when your social prescribing workforce reflects the population that you serve. And that's something that Tower Hamlets has done really well. I would say the social prescribers are almost representative of the population that they serve, and I think that's particularly helpful.
Well, hopefully we'll have more success with this than we do with the fire brigade or the police, both of whom organisations are doing everything they can in that respect to fill those posts. Jennifer?
It would be really, really good if it was to set out at the start, because the conversation can keep going on and on about whether you like the term social prescribing or not, but if it could really put something out there clear that it says, you know, you can call it what you want, you can like it or you can not like it, because the more time we spend talking about, oh, I think it should be called this or I think it should be called that, it's kind of wasting time. Just get on and do it and get out there, and sometimes the people who enter into those type of conversations are kind of slowing things up for different reasons. And might not be that action orientated type people, so it's almost like framing that at the start, just to say, look, this is what it is, it means something to different people, you call it what you want. It might not be around, hopefully if it all goes to plan, it'll not even be called social prescribing, but getting that out front and forward would be really good.
But it's getting the concept out, that's the problem, isn't it? If you don't have a name, people won't know how to self-subscribe, and that therefore would be a problem. Okay.
Just ask quickly, is there any example worldwide that does this well? I don't want a great detail, but is there?
Everyone's looking to the UK at the moment, everyone. Closely followed, like you've got Australia and Canada, but the UK has definitely been the leaders in this, from what we can see.
It's a good question. Right, if I can ask the GLA health team a couple of questions. First of all, I'm a little bit concerned that you're not aware of just how many GPs are using this or not. Because if you've got a vision, it's got to go out there, you've got to know what you're looking at and how much work's got to go into how many people. When do you think you might have those figures?
We're working on that now, both with the national team and with the London Healthy London Partnership. But I think it's not just about knowing the number of GPs, it's about the other services as well. And I think what was reflected here quite well is that there are so many different partners involved in developing social prescribing. So we need to find out more about the voluntary sector organisations that are participating and more about the local authorities that are co-commissioning or developing projects. So we're doing that work, it's ongoing. One of the issues has been that people don't, as we just talked about, the social prescribing, people don't necessarily use that term. So it's about sort of finding out more about what people are doing. But that work is ongoing, and the vision is obviously a 10-year vision, so we are looking to sort of keep developing that kind of information and keep growing it.
Will you have that information at hand though before this all goes out? Because
so we're planning to engage with primary care as a key major audience in this engagement event. What that means will be GPs as commissioners, so CCGs, and we've done the work with HLP partners around the groups of GPs that lead clinical commissioning in each borough. So we know that there's 25 of those CCGs actively looking at commissioning programmes, but we also know that in some boroughs social prescribing is led in other ways by primary care. So GPs have come together in federations now, in networks. So at a sub-borough level, and I'm speaking from previous experience in my particular borough, a particular GP federation was very interested in social prescribing, and it's evolved in that way. And then we've got individual practices that may work collaboratively at quite a local level, some of the bigger practices. So our GP engagement will need to hit all those different ways. So GPs as commissioners through CCGs, working at a borough level. They might be piloting in part of their CCG, or they might be doing it whole CCG. We'll be talking to GP federations, where groups of GPs are coming and looking at how they provide services together for smaller populations. And we will also look at, are there examples of GP practices with a particular interest where they haven't been picked up through the CCG or the Federation, if that makes sense. What we haven't done is go down to, at the moment, do any kind of survey work at an individual GP practice level, to look at this. I think we would hope, from terms of engagement, that we'd get this out there to all the practices. And then I think as part of the engagement, we'll have a look at what kind of responses, engagement we get back, and then take stock at that point about how this vision can best support those practices.
Well, yes, because there could be great big holes of whole boroughs not working.
So,
and I'm taken with what Dan and Mohan both said. Mohan with the fact that, Dan said it should come for a GP first, so that you make sure that there's no clinical issue, etc. I was just saying that the Mayor's vision has 3 objectives: provision for all. Well, if it's provision for all, we really do need, in my humble opinion, to know where these massive gaps could be. And if we don't know which GPs are even thinking about it, we may have massive, great big gaps. And that certainly, therefore, won't lead to provision for all. And if there isn't provision, we need to know where there isn't provision. Because in boroughs that don't have such a fantastic third sector as Tower Hamlets, etc., it's going to fall at the beginning. So really that needs, in my view, to be really established before we, you can have a vision, but you've got to know what you're...
So we've got 8 boroughs that don't have social prescribing in their current plans. So we know that, that's significant. Out of the 33, we've got 8 that don't currently have plans around social prescribing, even at a borough level. And then your point noted around what would we then do as this goes forward over the 10 years, particularly if we do have central government announcements around intention, which will, I think, change the conversation a bit as well with CCG commissioners and with GPs potentially, as to what that looks like. So I think hopefully this engagement process, if we can do it both for GPs as commissioners, through CCGs, GPs in their federations and how they're organised, and then also on a practice level, through this 3-month period, in light of, whatever the national announcements are.
Yes.
Hopefully at the end of that period, we'll be in quite a good position to take stock of where we're at in London around what the ambitions are.
Okay, because obviously 8 boroughs is one hell of a lot of people that won't have any interaction at all.
Could I just add to that as well? We're also obviously very mindful there are other people commissioning services. We've just commissioned the Housing Association Charitable Trust to do a piece of work for us looking at what each of the housing associations based in London are doing. We've just received a report a couple of days ago that sets out what every housing association is doing, what they're looking to do in the future, how they would like to engage with us and NHS and other partners. So we're also looking at other avenues for delivery as well.
Okay. Will your delivery plans have specific targets? I mean, one of the things that we're always irritated about is that very many of these things are like a wonderful wish list that go on into the distance, 10 years away. No specific targets, nothing that we can hold anybody to account to. That's been going right the way through everything that's gone through, certainly since I've been on the Assembly. What specific targets are you going to have in that vision?
So in terms of, we'll talk about, there's targets for the Mayor and the Mayor's role in this, which is what we've tried to capture in the Health and Equalities strategy, which in this space are less about the GLA having the mandate to commission a social prescribing, because the Mayor doesn't have those powers around health and social care, but have been more to do with the convening power around bringing partners together, developing the vision. As the vision looks at what are the particular priorities in London, so we've flagged workforce, we've flagged the digital platforms that can support social prescribing, we've flagged the issues around social and legal welfare advice, then there's an opportunity there for the partnership as a whole and the partners within it to make specific commitments potentially as to what the role they can play in taking this vision forward. So the ambition overall is to have this rolled out across London. As I say, it's only in 25 boroughs at the moment, so there's that ambition there to roll it out, to make it available to all to the extent that people can access information and advice. And then as we get better quality kind of data and sense of ambition from the areas, we can then start to look at things like uptake, are the right people that can benefit from this accessing it in the right way. But we're a fair way off that at the moment, given the starting point is we only have 25 boroughs engaged at the point of actually having anything in place.
Okay, so let me try and pin you down a little bit. If a fair way off is what? 6 months, a year, 2 years? Because everybody's going to be interested, and the other issue you've got is that there is short-term funding on various things that are connected to this. So if it's kicked too far into the distance, other funding methods will go and we won't achieve anything. So if I can just pin you down, when do you think that we'll have this across the whole of London? And when will we be able to hold you to account for some of the targets, or to be able to see, and for all our partners to see the targets that you're aiming for?
So there's clear commitments around the vision, consulting on that vision and how that's received. I think this national announcement, which in terms of the NHS plan, if that does lay down some some requirements for local areas to embed this, will give us quite a different platform to negotiate this vision with the health and care system. I think, commitments around, if this vision is accepted and the work that we need to do around workforce development, digital platforms, legal and financial advice, then I would hope that we would be in a position to pin down in quite concrete terms what would the delivery be of those elements of a social prescribing scheme. But if you're saying what can the mayor do, can the mayor set out an aspiration for the health and care system to establish this? I think the GLA could do that, and with the committee, the committee is clearly interested and involved in that. The ability to then hold the system, in detail to account on that would be tricky. We'll come back to the consensus around this as the vision and something that the health and care system wants to move to.
Okay.
Would you mind if I just... It's just that there are specifics in here which you could get. You could have a KPI about and put a time. I think one of the things that the mayor is saying is that, and we haven't seen the vision, we just know somebody who has. You will create a forum to share best practice. Well, that's an aspiration. When are you going to do it? When can we check the box? There are other things in there. This committee, this assembly, gets extremely frustrated with the mayor who says he's going to do wonderful things and doesn't tell us when he's going to do it. Or, in fact, actually doesn't quantify what that wonderful thing is. And so it's very frustrating for us, and we don't want to go through the grief that we had with the health and equality strategy, to be honest. Sorry to intervene, it's just very frustrating.
As an observer, I think 25 out of 30 people, I think that's actually quite good uptake, and I think we struggle getting it in our practice internally, and I think we've got that good coverage across. And I would concentrate on that, get some good results from that, and then the other 8 will go, well, can we have it now? And that might be part of what you plan, because I think you're getting it across everywhere.
I accept that, but actually going back, Vicky, if I may, it's a big part of what you're doing. So in your head, when do you hope to have some of these actual targets in place? When are you looking to do that?
So we are, through the advisory group, engaging on the vision for the next 6 months. That will put out some proposals of what is it at a London level is going to help to enable this embedding of social prescribing. On the back of that, depending on the responses that we get, what I would hope we would do is have a fledgling strategy that we'd work with partners to say, okay, how are we going to take this forward in concrete terms? Within the GLA, we can have conversations with other bits within the organisation about what their role is in supporting social prescribing opportunities, whether that be arts and culture, whether that be environmental volunteering, etc. But we will need to sit down with partners and with the statutory responsibilities that they have and funding to the timetables that they're working through and negotiate that.
Okay, it's just that so many people are working so hard on this. I'm impressed by the sound of it because I've not come across it much. It would be awful if people thought this is just a talking shop and it will go on and on and on and kicked into the future. So perhaps when this does come through, we will be asking exactly the same questions and really expecting some answers on that in the meantime.
Sorry, could I just add to that? Throughout the whole development of the vision, we've been working really, really closely in partnership with with all of the agencies that are here and many others, right across the voluntary sector. And it was really important for us that during the engagement period that we allowed, that it's a proper engagement period, and that people are allowed to comment, that we're allowed to agree aims and ambitions and timescales together, so in order to make it achievable, and also to pick on priorities, because as you've heard today, there's an awful lot of different priorities that could be focused on in terms of developing social prescribing in London. So we're very keen to sort of develop, carry on during the engagement period. We have a number of events planned and a number of things that our partners will take forward for us during that period.
That's excellent, because if at the end of all those consultations you come up with actual plans with specific targets, yes, we'll be very, very happy, and I'm sure everybody here will be as well. Can I just finish on really, how are you going to focus on disadvantaged groups?
Yeah, we've been talking to, again, we've been working through our engagement plan in terms of who we're going to talk to during that period. I've been talking to, obviously, to our civil society team here about who we should be targeting, who we should be talking to. We've got a number of range of events to sort of talk to them. We also, during the initial scoping phase for the health inequality strategy, we had about a dozen events with different disadvantaged groups to talk to them about what they see social prescribing is, what they think the barriers are, what the issues are. So we'll be picking up with all of those people again. So we have a whole engagement plan for the next 3 months.
Okay, and you'll be more specific on what a disadvantaged group is, because there are so many.
Yes.
That's fair enough. Okay.
Okay, in the formation of your vision, what was the level of engagement with the NHS and the London councils? Because it's about bringing the councils together and the NHS together. How involved were they, right, in coming up with this vision?
So the advisory group has been convened through Health in London Partnership, which is operate on behalf of that partnership, including London councils, NHS.
And the challenge we have, of course, in London, we have 32 boroughs.
Plus the City of London, yeah.
Fun? And the City of London,
yeah.
right, okay. Yeah. And those 32 CCGs don't think all alike, right, and they have different challenges and all. And that's symptomatic of the fact that there's 7 boroughs who aren't involved. So the question is about how do we get this common vision developing, and I just want to see what the process was.
So we have good relationships through the Directors of Public Health Network. So I'm a member of that network. I used to chair that network. So they are representatives from each of the boroughs from a public health perspective. They would sit on the health and wellbeing boards in their boroughs. So we've used those networks. Directors of Adult Social Care as well, network. Through the chair, getting their involvement, invited a representative onto the advisory group. For children's services, we've had some engagement around social prescribing for children, young people, particularly older children, young people. That's been maybe slightly less of a focus. I think it's a development area for the future. We've worked with London Councils, Clive Grimshaw, the policy lead there. We've also commissioned, the advisory group undertook to commission a piece of work around what does social prescribing mean from a local government perspective. And again, from previous role, it is a big opportunity in local government. So as Director of Adult Social Care, you're commissioning information advice. You are wanting to find as many ways as possible to keep people as independent as possible, to reduce statutory care needs, maintaining people's independence. Likewise for children's services around the core offer for vulnerable families, the troubled families programme. So the vision has been, we've got the advisory group, and they've commissioned some specific work around, well, what does this mean from a local government perspective? What are the key issues, opportunities, examples of local government-led social prescribing initiatives, which have reached out to primary care. So it's quite a mixed picture. And I think, I've only been in the GLA since February. I think the advisory group has tried to take that broad approach of understanding where are the boroughs coming from in terms of local leadership and what's made things happen. And how do you get that kind of quick exchange between boroughs that where social prescribing may have been led in a particular part of the system, to understand, well, how have they managed to make the case to other bits of the system? Okay. But it's complex. I'm not saying it isn't complex.
First thing I want to do is look at this as a very powerful testament. And I don't know of any GP in this whole country, let alone London, who won't think the social prescribing is a benefit to them. It gives them a useful tool to help their patient, given that 30-40% of consultations in primary care is socially linked to social problems. So I think this is something which is very good, and the challenge for us is to see how we can develop a common vision for London and how we can then bring the social services, the voluntary sector and the NHS together to deliver that. And that's a challenge for us, right? And that's a challenge which I think the Mayor has embarked upon, right? And I congratulate him for them, right? And I think it's about how we work collectively to deliver that. But I don't think of any, I can't think of any GP who doesn't think, right, that social services social prescribing is bad, right? And it gives a useful tool to help those patients whom we see. So I certainly want to, and I look forward to that, seeing that common vision developed, right? So, and that the committee will then be able to have a comment on it, as will other partners in the healthcare economy of London. So thank you very much for all the evidence you've given this afternoon. If you feel that there's something you wish you'd said or you've forgotten, you're still able to write to us so that we can feed into it as a committee, but also you can write to the GLA directly, to Vicky, and they will hear that. So I'll want to conclude at this end, right? Thank you for just to do formally. So can I please thank you for your contributions, and finally can I ask the committee to note the report and discussion with invited guests. Agree the scoping paper as attached in Appendix 1 and delegate authority to me as Chair in consultation with the Vice Chair to agree any output for the discussion.
Agreed.
Thank you. Can we please agree the following recommendations? Note the Health Committee work programme.
Noted.
Agree to use the 10th of January 2019 meeting as a slot to discuss issues related to organ donation for Black, Asian and minority communities, and delegate authority to the Chair in consultation with the Deputy Chair to agree any side visits, informal meetings or engagement activities before the committee's next formal meeting.
Agreed.
And can we please note that the next meeting of the committee is scheduled for the 10th of January.
Agreed. Thank you.
Any other business?
Any other business?
A press release went out implying that the Health Committee was unanimously in support of the Mayor's recent ban on high-fat foods on the tube network. That wasn't the case, and the Conservatives on the committee actually believe that the evidence isn't there to support the high-fat food ban in isolation from other measures. So I hope that we could exercise some caution in future when press releases go out, because
the press release was down as for the chair of the
it said that the Health Committee supported it.
And the Health Committee, I think we can put it to a vote, right, next time round, but the Health Committee does support that.
It just needed a rewording. I'm not asking for an argument. It's just a rewording of that.
I take on board what you say, and I'm sure this discussion will be changed by all police committees, and including the police committee. Thank you.
Thank you.
That was good.
GLA, Committee Room 5, sound. GLA, Committee Room 5.